Hey, good afternoon. This is Dr. Brian DeLage from the University of North Dakota School of Medicine and Health Sciences. I and Camille would like to welcome you to the Family Medicine Faculty Development slide presentation. Dr. Sherman and I, as the co-directors of the Family Medicine Clerkship, have taken upon ourselves to try to improve the grading and make clinical faculty aware of some of the changes within the School of Medicine that affect the clerkship, and trying to help our clinical faculty to be better prepared to help teach our students. So the purpose is to improve the students' and the preceptors' satisfaction with teaching within the Family Medicine Clerkship, to remove some of the variability in grading that exists between different preceptors, since 50% of the students' grade does depend on the preceptor evaluation, and then explain the goals and objectives and required clinical experiences for the clerkship. So the family medicine goals and objectives are the following: to enhance and refine data collection and problem-solving skills, to learn principles and interventions of health promotion and disease prevention that are maximally conducive to good health, to learn about healthcare resources or challenges in your community, and about principles of the patient-centered medical home, to recognize the reciprocal impact on patients and their families and of family, community, and culture on perception and reception of healthcare, and to develop an awareness of personal strengths, interests, and limitations that all should be gained through their family medicine clerkship experience. So how do we accomplish all of this? Well, first of all, we have two things within our syllabus called the Clinical Skills Inventory and the Learner Contract. If you go to the URL listed, the Family Medicine Clerkship at the University of North Dakota, you'll see our syllabus, and within that syllabus is this Clinical Skills Inventory. It's an inventory that the students should take at the beginning of their clerkship to figure out where they're at with their own clinical skills and to set up for themselves different learning objectives and which things they might want to work on while on the clerkship. And then the second thing is the learner's contract. The learner's contract is a helpful tool for you and the student that you should go over at the beginning of the family medicine clerkship to set goals and review this mid-clerkship, to reassess and decide whether to add or change goals and assess how the student is doing with the goals that you set within this learner contract. It's a tool to help you and the student keep track of how the student is doing and to help you and the student find out if you're meeting those goals and to readjust. So how do we accomplish all our goals for the clerkship? Well, number one, we do presentations to the students do have to do presentations to both the clinical faculty and the clerkship faculty. The students should be seeing patients with the preceptor, and then they should be seeing the patients and presenting this to the clinical faculty member. They should know about the sub format and should be presenting in that fashion, and then they should be asking for feedback on their presentation. The students also do a case presentation of the clerkship directors to assess their data collection and problem solving, as well as other points to include health promotion and disease prevention, the impact of family and culture, scope of practice, and then a learning issue. So how do we accomplish this? Well, number three, we do an orientation at the beginning of the clerkship with the students. This is a video conference that the students participate in, and usually is done Wednesday or Thursday morning of the first week, or afternoon of the first week, usually starting at 1 o'clock. We'll do a presentation and talk to the students about the orientation. We'll also present a PowerPoint on the patient-centered medical home, and then they are asked to observe the parts of this that may be put into effect in your clinical practice. If you are a clinical site that has adopted all of these policies and is a certified patient-centered medical home, that'd be a good thing to share with your student. The students will also be seeing patients in clinic and giving appropriate age-specific health promotion and disease prevention recommendations. And then we also do further video conferences, including Access to Care, which is usually the third week, and Family Connection, which is usually the fifth to sixth week of the clerkship. These are video conferences to address the social issues that affect effective healthcare delivery. And then lastly, they should be participating in their preceptors practice. They should be seeing patients and observing the delivery of healthcare by you. They should be actively participating in this care as much as possible and practicing these presentation skills, as well as adding to their clinical acumen by doing research about some of the different disease states that you're seeing and being able to present back to you information that they've gleaned from that. There are some changes to the clerkship and the requirements. The Clinical Sciences Curriculum Subcommittee has recommended that we change to address the findings from the Liaison Committee on Medical Education. They came through and did their survey in 2013, and we are still trying to make some adjustments. There were no seriously major problems. However, there were a number of issues that need to be corrected for us to continue with accreditation. One of those is that there needs to be some required clinical experiences for the clerkship. So the family medicine clerkship has developed 22 required encounters that the students have to at least have seen or studied a case about for completion of the clerkship. As you can see, these required clinical experiences follow along the lines of most family medicine practices. They need to perform an adult wellness exam, pediatric wellness exam, and well child exams, and perform a newborn exam. They also should be seeing diabetes, cardiovascular disease, stroke, hypertension, abdominal pain, upper respiratory illness, lower respiratory illness, dermatitis, skin lesions, back pain, musculoskeletal complaints, obstetrics, gynecology, mental health, headache, red eye, and also they should be looking at the family dynamics and patient access issues, as well as oral health. With the red eye, there will be an online lecture that the students can look at if they have not seen conjunctivitis or anything else causing a red eye and have not been able to research that themselves. There'll be an online lecture that we'll have for them to complete that requirement. Also, the family dynamics and patient access, we do access to care and family connection video conferences. So those video conferences will actually have all of that within them. So they will accomplish that by participation in those video conferences. The oral health, if the student happens to work one day with a dentist, or you see a tooth pain in the emergency room with the student or in your clinic, or if the student actually does the Smiles for Life program. There are also family medicine cases that pertain to all of those other diagnoses that the students can do on their own and log those to complete that requirement if, say, they did not see an abdominal pain while on the clerkship. So we ask them to review their list by about the 5th week, and if there's any deficiencies that they go ahead and do the required remediation. So all of these can be accessed on the syllabus, and they will go into effect in the 2015-2016 academic year. The focus areas for family medicine applied by the CSCS have been the dermatologic and musculoskeletal examinations and working on these, as well as health promotion and disease prevention, which we also share with internal medicine. So we will be checking their logs to make sure that the students have seen these areas and are logging those appropriately. So we do actually talk over with the students some mistakes that the third-year medical students make that set them up for failure. One of those is beginning the rotation without a clear sense of what the evaluators are seeking and underestimating the importance of faculty comments. So when we do their orientation, we tell them to go over the learner contract and ask you for feedback regularly, and they should be paying attention to what you have to say there. Then quickly glancing over the clerkship evaluation form. So if they haven't looked at the clerkship evaluation form, they're not going to know what areas you're going to evaluate them on, and they may not be fully aware of all the different areas that we do evaluate the students, including some areas on professionalism. And then remaining unfamiliar with the goals and objectives of the rotation. Those are all reviewed in their orientation, but the students sometimes have to be reminded of that. And then not seeking mid-rotation feedback meetings. So the student should be asking you for some feedback, and if not, you should bring out the learner contract at least halfway through, or if they're on a 4-week rotation at the 2 or 3 week mark, to set other goals for them and to see how well they're meeting those goals. The evaluation of the student is 50% of the evaluations by clinical faculty, evaluation of the student clinical performance. That's the evaluations that you'll be sent a link to for eValue. Then they do get 10% of their grade from their case presentation to faculty. They will get 20% of their 30% of their grade from the NBME Family Medicine subject examination. Then they'll get 10% from small group presentations, as well as their clinical encounters database. And then that comprises all the evaluation points that they will get. They also do have to complete their student evaluation of the clerkship and the student evaluation of the preceptor. So how do the preceptors rate? Well, the students evaluate the preceptors in the clerkship, and the students typically rate the family medicine experience as one of the highest within their medical school curriculum. And they rate the preceptors quite highly, and they indicate that they are the best thing about the clerkship. So your comments, time, and energy are appreciated and highly rated, and are the most important way that you shape and mold the students. The way that you interact with the students, even if they don't go into family medicine, does shape and mold how they perceive family physicians. So it's very important for us to have them do this required clerkship, and we really thank you for that. How do you rate them? Well, the average preceptor rates the students, an average student at about 92%. The range was between 84 and 100%. Now, 80 to 90 means that they meet your expectations for an average medical student in their third year of medical school. This relates to professionalism, skills, knowledge base, and presentation and medical reasoning skills. We have set an average of 93% in all scored areas for honors. So the student needs to score in the top half of the class on the NBME exam to be eligible for honors, and the preceptor evaluation must be above a 93 typically for them to usually make honors. So if you look at the forms, all threes would give the student an 84%, all fours would give them a 92%, all fives would give them 100%. Now, not all students are all fives and are ready to enter their intern year, but some areas that students typically can garner a 5 in would be areas like professionalism and rapport with patients. So about 20% of the class typically gets honors, which is the percent that CSCS and the medical school have set for honors for each clerkship. So far for 2014 and 15, we are sitting at 21.4% receiving honors through the first half, and the second half is looking like it's going to be slightly above 21%. So how do you rate students? This is where you should go over your average score for the student who you have rated in the last year. Think back and look at that email. Did the students you rate get fair evaluations? Compared to their peers who are averaging 92%, with the escalation of grades that has happened, did the average student you work with get an average score? So how to adjust? Did they appear ahead of your expectations for a third-year student and yet scored below that 92%? Then consider a score above 3 in different areas. Students can have very good interpersonal skills and get along well with others and be average in terms of knowledge and skills, but still get some 5s in professionalism and ability to interact with patients and staff. So any suggestions that you have for us to change this process or to change the clerkship would be welcome. The form that you fill out was developed by the medical school and is uniform across all the clerkships. So changes to that particular form or what we should be evaluating do need to come through the clerkships and brought to CSCF for changes. So if you have any of those, please feel free to send them to me by email at brian.delage@med.und.edu or camille.sherman@med.und.edu, or you can call us anytime to the department 701-777-3081 will get you to my office. So thank you for your time. You are the reason the students typically rank family medicine as one of the best clerkships for the third year of medical school, and why the UND School of Medicine and Health Sciences continues to be a national leader in students choosing family medicine as a career, even though nationally it's lost some of its popularity. So we'd like you to keep up the good work, keep helping our students choose family medicine, and thank you for your time.